we are now going to have a session on research processes and the importance of good project planning, because obviously you have to convey that you know what you're doing to your reviewers. So some of you may have recognized that as the Artemis 2 10-day mission that was launched on the 1st of April 2026. I just thought I'd throw a few facts and figures at you. So this was the first manned spaceflight for quite a while. They had 4 astronauts. It took 10 days, 685,000 miles to the moon and back. And you'll see that actually they went around Earth more than once. So they went a lot further than that. On the launch pad, the Space Launch System and the Orion spacecraft that sat on top of it was about 322 feet high. They had 5.75 million pounds of liftoff weight, 8.8 million pounds of thrust at launch, 730,000 gallons of liquid nitrogen and oxygen, 33 engines in total with all the boosters and various little engines they had all over the place. And when we think about the re-entry of the Orion spacecraft, where the astronauts are basically living, its speed on hitting the Earth's atmosphere is around 25,000 miles per hour. That's 33 times the speed of sound. The air temperature around the module reached about 10,000 degrees centigrade. It basically turned into plasma. And the heat shields that protected the spacecraft went up to about 3,000 degrees centigrade. So it was absorbing some of that heat. During the process of slowing down, 11 parachutes were deployed at different times. And it basically got down to a speed of only 17 miles per hour when it splashed down. So what's my point? I think my point is, aren't you glad you're not doing rocket science? Because if you think about the logistics and the project planning that's involved with something like a space mission, it's absolutely enormous. But that's not to play down the difficulties of putting together an applied health research project. Logistics are terribly important. So you need to consider all the logistical aspects of your study before the application and not afterwards. Obviously, you've got a cost for them all. You've got to budget for them all. So you've got to know what's going to happen. You won't do all of the things I'm going to talk about at the application stage, but you should consider them all when you're planning and timetabling and costing your study. Thinking back to the 4 key propositions, it covers the success criterion, the value for money criterion, and the sort of competence criterion that Aldridge and Derrington mentioned in their book. So let's think first about some research processes. A bit of context is helpful, I think. Obviously, there have been loads of documents that have been published over the years by the government and others that have influenced the research agenda. We've got good clinical practice, which obviously was early on, but now we all do GCP training of health professionals. If you're undertaking research, you've got the UK Policy Framework for Health and Social Care, which is the former Research Governance Framework, which I think is actually a really good document. It's a very straightforward document. It's not full of jargon. It's easy to understand. It tells you what everyone's supposed to be doing in research, which is helpful. Best Research for Best Health, which introduced sort of infrastructure and systems. We've got the 5-year forward view and the long-term plan, and more recently the 10-year plan, which has helped to identify funding priorities and various new initiatives. We've got the NHS Constitution, which basically wanted to promote and get people to get involved with research and a commitment to inform patients of them. Saving and improving lives, about research delivery. And again, Health and Care Act, new duties to promote, facilitate and use research. So a lot of documents over the years that have provided a context in which we undertake our research. And as a result, you know, there are various processes and things that you need to do, hoops that you need to get through when you're undertaking a research project. So all research carried out in the NHS requires a sponsor and R&D or research and innovation approvals. Most research will require funding. Most projects, you know, if they're going to produce something useful, are going to require funding. And most will require ethics committee approval. And there is a little decision tool that the HRA have on their website, the Health Research Authority have on their website that you can use. But most research will require ethics approval. Some research will require other approvals, such as clinical trial authorization. You know, and obviously with medicines and investigational medicinal products, you're definitely going to need other approvals. like that, and MHRA, other MHRA things. And some research will require research passports, either honorary contracts or letters of access for researchers to get into a clinical space. The research support services, NIHR funded, that's us. We're here to help you put in your research grant applications and to help you in a fairly limited way post award if you run into trouble or need further help. The Health Research Authority is there to obviously deal with all the sort of ethics and governance issues and to make sure it's all done properly. R&D offices tend to be local offices, either within universities or trusts who will want to know about the research that you're doing, and you'll have to register it with them and you'll have to go through them and tell them all about it, and they'll help you cost it up. The Research Delivery Network is the used to be the CRN, the Clinical Research Network. So the name has changed recently, so that might be why some of you didn't recognise it. But they're there to help facilitate the sort of logistical and practical aspects of your work. You go to them for help with sorting out what your NHS support costs and whether there are any excess treatment costs, and they can also help you identify sites and link you with clinical experts and clinicians who might be happy to be involved in your research. Clinical trials units are there to help you sort out the design, stats, often health economics and other aspects of your study design, and they can help to varying degrees, either just providing a sort of service like a randomization service, or they can actually help run the whole thing. So they're terribly useful people and are necessary for certain types of trials. Technology transfer offices, yeah, usually they are lurking in some form, either within R&D offices or as specific offices. Universities, to varying degrees, will have somebody on campus who's responsible for dealing with sort of intellectual property that you may be producing as a result of the research that you're undertaking. Oxford University, for example, has a massive TTO called Oxford University Innovation, and if you're doing research, they want to know, and they will help protect your intellectual property and license out anything that you develop and create spin-out companies. The MHRA, of course, is important for medtech and pharmaceuticals that are being developed, and they have lots of rules and regs. Health tech research centres, again, are there to help you if you're doing research in the health tech space to get grant applications together. So they sort of work with us sometimes. They sort of have a sort of specific knowledge that can be helpful in the development of medtech. Health innovation networks are really there to get the products of research out there, but they can also help and be part of, for example, medtech applications. They sometimes do some light touch health economics or investigate NHS pathways for you, so you can involve them as collaborators. ARCs are sort of local organisations who have specific themes that they're following, but quite often they'll have their own little pots of money for things and their own research themes that you can sometimes work with them to develop your own work. And the health determinants research collaborations are new things that have been set up within local authorities. So this is the NIHR trying to get local authorities involved more with research. Lots of things to do when you're undertaking research. Don't get too bogged down with all these acronyms. I'm afraid, as you know, NIHR and health research is full of acronyms, but I have tried to describe them down there. I'm not going to go through them all, but basically when you've got a research idea, you talk to the RSS, you write your proposal, make sure you've got a sponsor, get sites on board, talk to your R&D and finance office, and if necessary to the RDN about excess treatment costs, and to get your SOCAT form signed off, which is basically to reassure the NIHR that you're not going to use NHS resources, or if you are, they've been costed in through the RDN. And there may be other things you do along the way, depending on the project you're doing, like MIHRA, you might get the RDN Study Support Service to help you. You might need to talk to a clinical trials unit or a TTO. But you can then apply for your funding. And then once you've got your funding, you apply for your approvals and attend to any research passports. And then basically, you've got a project that's just about ready to be up and running. However, this is not the end. It's not even the beginning of the end. It is perhaps the end of the beginning, as Winston Churchill said. I'm afraid I'm not going to attempt an impersonation like Bernard did on Monday or Tuesday. So project planning is all about the people you need, the materials, equipment and space you need, the time you need, and how you organise all of that. So it's the who, what, when, where, and for how long of your project. It's worth thinking about what will need to be done on sort of a day-to-day basis. Sometimes if you think about, oh, I've got to do this, you know, we'd have to recruit so many people, blah, blah, blah. It's helpful sometimes to do that at a sort of daily level, what will need to be done. And it's worth thinking about how to maximize benefits to all involved. And I think we heard a bit yesterday about how it's very important for PPI to be informed about the outcome of research, and we'll hear a lot more about that later today. But you know, if people are involved in research in whatever capacity, you know, you want to maximize the benefits to everyone. So, you know, people want to hear about their involvement. You know, if you're involving hospital sites or wards, you want to make it a pleasant experience for them. You want to make involvement feel like you know, a party. You know, send them thank you letters, keep them engaged and involved, talk to them regularly, don't take them for granted. You know, there are lots of different ways you can make everyone involved, and it's incredible. You know, when I think about you know, I've spent a long time in this space, and the way different academic teams or different teams of researchers operate. You get some who are like, it's a jolly party, you know, and they all have good fun and they get on brilliantly and they all talk to each other and value each other. And then there are others that really don't feel like that at all. And if you can make it a very positive experience for people, you know, you're going to keep people engaged and interested and on board and doing their very best for you. Just to show the importance of getting it all right, this is a rather sad article that was written for Health Technology Assessment. It was a randomized trial of coronary artery bypass grafting off or on pump surgery. And this is literally what was written in the abstract. And at the end, we have here, the trial was stopped on the grounds of futility after 106 patients. Less than 2% of the target sample size had been recruited in 18 months. And what a depressing thing to have to report. And obviously, if you do think through all the logistics and processes beforehand, the chances are this is less likely to happen. I mean, I don't know what happened specifically here. And of course, feasibility work can be tremendously important in making sure these things don't happen. But it all has to be planned and carefully thought through to try and avoid situations like that. So another thing you need to think about, obviously, the people you need, and there are different sorts of people who are involved in projects. You tend to have a principal investigator who has an award that fits their career stage, is sufficiently experienced to do what they're trying to do, you know, and you know, can demonstrate that in various ways. You then have co-applicants and the research team, co-applicants being those who actually appear, I guess, on the grant application, and the rest of the research team, perhaps people who you're going to employ afterwards. I think if you know you've got particular people who are going to be part of your team, who are perhaps early career researchers, it's very nice to have them as co-applicants because it will be good for their career. So don't take people for granted. You know, if they are going to contribute and you know who they are, then why don't you make them co-applicants? But yeah, the research team can be broader than the co-applicants. So you need the right skill mix, which we talked about, and a sensible contribution. So you can also have collaborators who may bring the right skill mix to the research team. And these might be people who perhaps aren't part of the research team specifically, but you're going to need them for part of the work. They may be site leads or consultants that you bring in for specific parts of the project. Often you'll have a day-to-day project manager depending on the extent of the project. So managing the project on a day-to-day basis. And in order to do that in a relatively large trial, it can be a very big job. Then you may have research assistants or research nurses who may be involved with consenting patients, data collection, collecting or processing samples. Some of those nurses might be working for the research delivery network, depending on how you set things up. And then, of course, you've got patients and the public who have different levels of involvement, but are important throughout, and they can help you think through recruitment and research inclusion. So there are varying degrees of PPI, and we'll hear about that later on today. And then there are other types of people, administrative staff who may be involved with support of that nature, consultants for specific help and advice. They might be co-applicants, such as statisticians, health economists, qualitative researchers, computing experts, or you may be bringing them in on an hourly basis or for short periods of time to help with specific aspects of the project. And then there are various support staff, perhaps people external to the study, but whose help might be needed, staff on wards, librarians, sort of local data protection officers that you might want to speak to during the course of the work. And then there are groups of people. A lot of projects will have a steering committee, again, depending on the scale of the study and who's doing it. But often you will see some sort of steering committee or supervisory or mentorship team who will oversee the work and making sure the study happens when it's supposed to. And often these will involve independent advisors along with key members of the project team. Some trials will need a data safety and monitoring board or data monitoring and ethics committee. That's not to mean that there aren't important ethical and safety issues in other trials and studies as well, which need to be considered and carefully looked into. But some of this is something, a DMEC will be required for certain types of trials. They're independent and they'll periodically check on the data being collected for patient safety purposes. And they will also have a broad-ranging monitoring of data quality and integrity role. And then there may be advisory groups, depending on the study. It could be patients, other stakeholders. And I think increasingly we want to see stakeholders involved, all stakeholders, and not just patients, but also other people who will be the ultimate users of your research or the recipients of your research results and be working with them. It's important to make sure you've thought through how to organise these people. So who is in charge of what? That roles are clearly designated, that everyone is committed in terms of time and interest. Sometimes it's tempting, isn't it, to put that super duper very well-known professor on your application, but if they're not available for you when you need them, you can probably do better. And staff management is crucial, making sure that everyone's happy and doing what you want them to do. So funding panels need to see how the research team will function and that the personnel are justified. In terms of logistics of people, well, you've got, in terms of patient and public involvement, the RSS and other bodies can provide help in recruiting PPI. And we actually have a pre-application fund that you can get from us called the Peer Fund. It can help you do that pre-application work, which needs to be done, and it's essential. And the PPI work has to be timetabled and costed sensibly throughout the project. So you have the sort of pre-application stuff, and then you have what's going to happen through the project. And then the logistics of research inclusion, so outreach, appropriate outreach to get to those groups who really need to be part of research but who are often neglected. Translation and interpretation services, specialised promotional material, etc. You're going to have to think about that and the time required to do it all, because that will impact on your budget. In terms of people still, staff, well, you need to liaise with personnel, develop job descriptions, advertisements, which can cost money. You need to interview people and obviously get proper references, because a lot of what we do in health services research is, and health research more generally, is often quite sensitive. Liaising with sites, with health professionals, information about the study, what will it entail, etc. Getting people on board. All of this takes time and therefore money, which you need to budget for. Generally speaking, in terms of participants, so we're talking about people who are involved as participants in the study, systematic reviews show that the originally specified sample size is recruited in a little more than half of clinical trials. And if you remember the quote I started this section with, recruitment is absolutely key. Patient and public involvement is often key, because they're telling you what it's like being a patient at the receiving end of an information sheet and invitation to take part in a trial. A clear recruitment plan and sampling strategy. Thinking through first contact and informed consent, what exactly is involved, who will be doing what, how long will it take, and are we doing it properly? Realistic timing. This is generally about recruiting participants. Realistic timing. So a really good thing to do is to look at the local data, apply your eligibility criteria, and look at the throughput and the variation caseload that you get. So it's feasibility work of sorts. It doesn't necessarily mean that it's a feasibility trial, although a feasibility study, although that's very useful. Even just looking through, for example, in a hospital, who comes through when, how many of the particular group that you're interested in recruiting, is very comforting to reviewers for you to be able to say, well, in the last year we had X number of people who fitted our eligibility criteria. They'll like that. The importance of being inclusive, and you talked about outreach, etc. So be inclusive of minority, underserved, disadvantaged, particular socioeconomic groups, and describe provision for overcoming poor literacy, language, and other barriers. And you'll see that in NIHR applications, this is invariably an obligatory section that you have to fill in. How are we going to make sure that those who really suffer from these conditions are involved in the research? And of course, feasibility work. So all of these things, if you get them right, can help with your recruitment. So that's people. What about communication more generally? So before the study starts, you need to think about who should be involved with the study and who should know about it. And there are lots of different people who should know about the study, maybe senior managers in the places that you're hoping to gather data, healthcare professionals, medical records officers, perhaps the pharmacy, clinical ward clerks maybe, general practitioners, and obviously with different sorts of research. It might be in a social care setting. You need obviously the managers there on board and the staff on board there. So people are going to have to know about the study, and you need to let them know as soon as possible, really, that that's what you want to do. You may need formal agreements between collaborators, so in relation to sponsorship and financial management, data ownership and authorship. These are the things it's worth thinking through beforehand to avoid fisticuffs later on. The Health Research Authority for ethics and global checks for R&D, the MHRA in some circumstances, your local trust R&D offices to discuss treatment costs, confirmation of capacity and capability, the Research Delivery Network for cost attribution. So most grant applications, certainly NIHR, like to see a SOCAT form signed off. Sometimes even if you're not actually going to use any NHS resources, they simply want to see that it's gone through the process and they know they don't have to worry about them. And the RDN can also help recruit with study sites. Clinical trials units, obviously, if you're going to involve them, they need to have been involved in the development of the application and to be a applicant on it, or their staff. And you need to think about external communications, websites, press office, how you're going to deal with it. So start talking to people early on. And if you have people on board, the funding application is more convincing. So the more you can say about what you've done, it plays to the success criterion. Ongoing communication once the study is up and running. So clearly defined roles between researchers, some sort of chain of command and appropriate support. If your local data collector breaks a leg, you want to know about it, because otherwise you'll have a massive gap in your data. That actually happened to me once. To ensure data quality, you need to reach out and reaching your project milestones. You need to talk to people. So making sure that you're regularly looking at the data, checking the data, talking to people who are collecting data. There may be ongoing communication with the ethics committee if there's a change in protocol, methods, dilemmas, etc. Ongoing communication with participants, so a contact person for everyone whenever required. So that depends on the study, whether it's every day or actually on call. You probably need a complaints contact, so people got someone to talk to if they've got a bit of a beef with the project. Backup information was helpful, as long as what you're doing isn't interfering with the intervention, for example, you're trying to evaluate. So I remember doing my PhD work, looking at housing, dampness and health, coming across people with issues and problems with the council. It was helpful to have leaflets and information about other things that they might want help with. Ongoing communication with study sites, personnel, politics and facilitation, clearly identified researchers on the ward, general information exchange, query answering, troubleshooting, and importantly, feedback and acknowledgement. And all of these things take time. So, you have to build in the fact that you are going to have to go around your sites and check everything's going well. And that's going to impact your travel budget as well. Other resources you may need to consider, these sorts of things. I mean, some of these will be covered, maybe included as institutional overheads by your funder. So you do have to see what your specific funder wants. But, you know, you've got equipment, postage, software, data access, printing, stationery, transcription, samples and tests, travel, staff training, telephones, you know, all funded one way or another. And importantly, if you're doing people are out in the field, sort of mobile phones and ensuring that they're safe is important. So safe working practices. So logistical considerations in relation to the study design specifically. So this is how your proposal can be operationalized, you know, sample selection and monitoring of recruitment, if applicable, randomization and arranging an intervention. So it may be that it's already funded, maybe it's getting funded via NHS excess treatment costs, training and fitting the care around pathways. So you need to assign responsibility and ensure time for all these things. And then there are logistical considerations in terms of data collection and data management. So measuring outcomes, so you may need to find the tools, and there may be permissions associated with tools that you're using if they're off-the-shelf, valid and reliable tools. If you're developing your own tools, you have to bear in mind validity and reliability issues, and make sure that whatever you're developing is valid and reliable. It's got face validity, etc. Lay and non-English speaking issues. Important, very important. Collecting other information, sort of process information, administrative and contextual information that will help you run the study. Computing databases, remote data collection, you know, do you have the expertise for that? You know, do you have to build databases and platforms to help you with that? Only collect the data that you need to answer the question. It's very tempting to bung in a load of other questions, but at the end of the day, if it's not relevant to the research question, it's a burden for participants, an unnecessary burden. And then, you know, if you are doing some initial data checks or if you've done feasibility work, check that it all makes sense and that there's logic and sanity to what you're doing. So thinking through how will the data be collected, by whom, where and when. If you're using big data, the application process and the time this takes, this may ring a few bells because these were the sort of reviewers' concerns that we were talking about yesterday. Holidays and bank holidays. I don't know if anyone uses the post nowadays, but you know that can certainly be an issue, and some people will still want to have things in paper form to make sure you're getting everybody involved. Data checking and quality control, so double data entry and things like that. Do you need a data manager? Thinking carefully through information governance, so data security, data protection impact assessments. Procedures for reporting adverse events, computing issues, sort of coding and data entry and data cleaning. All of these take time. Thinking about biological samples. So are you going to analyze samples in-house or is there a central laboratory? How are you going to transport samples? Do you need a specialist courier? Ongoing transport elsewhere, or storage, are fridges and freezers an issue? When I talked to one R&D lead about this presentation, she said, tell them to get fridges and freezers. They're always filling up their fridges and freezers with their research samples. Get their own. And provision, if necessary, for long-term storage. So, you know, if there are issues relating to biobanks or there's the Human Tissue Act, for example, to bear in mind. And then for CTIMPs, trials of investigational medicinal products, also a whole set of other things that you need to consider, NIHR approvals and costs, preparation and supply of drugs and placebos, thinking through the supply, the packaging and the labelling. Who's responsible for pharmacovigilance? Is it a contract research organisation or clinical trials unit? And you will need to get specific advice from your sponsor. And similarly with some medtech, there are rules and regs about using medtech in research. So if you've devised a new medical device, you will need to get permission from the NIHR to use it in your research if you're using it clinically. Feasibility and pilot studies are brilliant, and they are very comforting to reviewers if they know that some feasibility work has been done. So people define these differently depending on where you look. This is the NIHR's sort of definition. So feasibility studies for them ask whether something can be done and should we proceed with it, and if so, how. pilot studies they see as a kind of subset of feasibility studies where you're actually doing more of a dry run of the actual definitive study that you hope to do in the future. If you're using the data in the pilot for the main study, it's an internal pilot, and if you are doing it separately and you want to make changes following the pilot, it would be an external pilot. But all of this stuff basically helps you reassure reviewers that any definitive trial that perhaps you're applying for funding for will work, you know, that you've tried out everything and it will work. And of course, if you are doing pilot or feasibility work as part of a program grant, for example, you need to cost for it and ensure you've got time to do it and timetable it sensibly. There are also logistical issues related to data analysis. It has to be planned before the study has started, broadly speaking. So a statistical analysis plan, and maybe something you develop, you know, in the early stages of a research project, but you need to have a clear idea when you put in your grant application as to, broadly speaking, what analysis you're going to do. Similarly with health economic, qualitative and other methods. And the equipment that you'll need, because obviously you're going to have to cost for the personnel, the time and, you know, the equipment. So you do need to know that before you put the application in. And then there are logistical issues in dissemination. So another couple of quotes: we know from follow-up of registered clinical trials that about 50% are never published in full. At least 50% of published reports are not sufficiently clear, complete and accurate for others to interpret, use or replicate the research correctly. So there's no point doing a research project if you don't then let people know about it afterwards. And it can be very difficult. You know, if you're a contract researcher, you're expected to move on to another grant and actually you've got that to deal with, and the last thing you want to do is to be thinking about the grant that you've just finished. However, that is why it is important to build into your timetable enough time and money to do that dissemination. It's also important to demonstrate clear planning. So Gantt charts, which invariably the NIHR will ask for. Flow diagrams, brilliant. Milestones are often asked for. And you can draw, I think, you know, in the example of the worked example yesterday, I think you saw how you can draw on, or was it, we definitely had reference to this, draw on published guidance to see what would be expected in terms of your protocol for your own research, the sorts of things you're going to have to gather. You know, so making sure you know what you're looking for and you know what you have to do at each stage. If funders can't understand your plans and see that they make sense, they really won't fund your study. Finances, a lot of people you're going to need to involve. So your local university or NHS R&D finance officer, basically to discuss research costs and excess treatment costs, because obviously you will have to go to the RDN to get that sorted out if you're going to use NHS money for your intervention. Collaborators, finance officers, so you have to check that they're all happy with the costs and happy to sort out the contracts. And as I say, the research delivery network are there for cost attribution, so sorting out whether, you know, it's a research cost, an NHS support cost like consenting patients, or whether it's an NHS treatment cost like an alternative intervention. And then if it is an NHS treatment cost, that they can then fund that for you, and if it's an NHS support cost, they can also sort that out for you. So it may be important to talk to them, and there will be time involved, obviously, in doing all that prior to putting in your grant application, and probably actually ongoing if there are other things to sort out. So always consult your finance officer at an early stage. Be aware that costs are likely broken down by project year, which may not be the same as financial year. Timings for university or trust sign off, maybe a week or two before the deadline, or maybe 3 weeks before the deadline of the actual funding application. And then if you've got the RDN and SOCAT to sort out as well to get it signed off. For fellowship applications, be aware that as well as applying for the finance for your fellowship via someone like the NIHR or Wellcome Trust, you also have to apply for the actual PhD at the higher education institution. Even if you come armed with a fund, if you haven't already applied and secured your PhD place, they won't want you. So do make sure you're aware of the windows that they have for applying for those and ensure that it fits with your funding application. Be aware of which organisation is responsible for project sign-off. The system will not necessarily be in place to sort out respective costs between collaborating organisations. And I've spoken to finance officers in HEIs who say it's taken us years to get an agreement in place. So these things do take a lot of time. Be aware of participation and costs of other collaborators, and also all of that needs signing off. And formal collaboration agreements and contracts is helpful to have in place before funds are distributed. In terms of the overall budget, have you considered how will resources requested be used? How realistic and accurate are the costings? Have you found the best price for tests, etc.? Is anything over budgeted or could be perceived as over budgeted? Are requested resources justified? And most funders will ask you to justify your resources. Do you have an efficient use of resources? And at the end of the day, is it good value for money? So if funders can't understand your costs or feel the study is not good for value, money for value, they may not fund it. And it's important to give yourself some leeway, although, we can't just bung, 15% on top of everything just in case something goes wrong. You can build in a bit of flex into your funding because, unexpected things will happen. There will be delays. There'll be things you haven't thought about. So you need to have a little bit of flexibility there because funders are unlikely to extend your project. They'll only do that in very, very unusual circumstances nowadays, I suspect. Some useful links for you. The sorts of things I've been talking about, the networks, the various collaborations, and CTUs, etc. They are all easy to find, and they are obviously important people to include.